Ήθελε να μιλήσει για το μέλλον και μελλοντικές θεραπείες, που είναι πραγματικά ένα δύσκολο θέμα στο γλαύκομα, γιατί και η πληροφόρηση πολλές φορές δεν είναι αρκετή. Θα ακούσουμε λοιπόν τι έχει να πει.
Good morning, ladies and gentlemen. It is really very nice to be in Thessaloniki once again, and I have to mention that this is the hometown for my wife's family, and actually all my parents-in-law, they were from Thessaloniki area. And I would like to thank to the organizing committee and to Tassos, my close friend, for the kind invitation of me for this very prestigious glaucoma panel. What I will try to do today is actually go back to past and look for the future and consider the present time. And I think there is some change during the time, and I know that there is a hard task of being in ophthalmology practice and see how a person, a very young and handsome person, takes the complexion of the present. And I don't know what future will bring, and actually this is the sunset photo.
Έχω ένα προδότη στο επιτελείο μου προφανώς.
So, my task today will be actually dealing with what we have in the pipeline, and we have a very close friend, Monsieur Chibre, as far as I can see, sitting over there. So they are the innovators, and we had very good discussions with Monsieur Chibre. Actually, before going on with the future, we have to look at the different components of glaucoma neuropathy. And this is basically a loss of neural tissue, activation of microglia, and tissue remodeling and blood flow disturbances. This is just a summary what we actually have in our glaucoma practice, the clinical picture from the panoramic side. And looking at intraocular pressure and glaucoma, still the elevated intraocular pressure is the most important risk factor in this respect, and for both onset and progression of glaucoma. Why this happens? This happens because there is increased extracellular material in the trabecular meshwork. And this is a depiction of disturbed balance between the extracellular material deposits and degradation. And also there is a disturbed balance between TGF-beta and the bone morphogenetic proteins, which are actually the targets for future treatment of glaucoma. And lowering of the intraocular pressure remains the only current therapeutic approach. So what the future will bring us? We will be dealing with baroprotection. This means lowering and controlling the intraocular pressure so that there will be no progression of glaucoma or no onset of glaucoma. And we will preserve the blood vessels, and we will restore the circulation. Neuroprotection has been elucidated by Dr. Boskurt, and we have the gene therapy just ahead, whether it is a telltale or whether it is going to be a real contribution to ophthalmology. Baroprotection in future can be done in three ways. We can increase the trabecular meshwork outflow, and secondly, we can increase the uveoscleral outflow, and thirdly, we can decrease the aqueous humor production by the ciliary epithelium. And to increase the trabecular meshwork outflow, we have two main new therapeutic targets. So the future lies here, and actually we can change the behavior of the trabecular meshwork cell activities. We can affect the cell volume of these cells, we can loosen the cell-to-cell junctions, and we can loosen the cell-to-extracellular matrix adhesions, or we can just modify the Schillem's canal inner wall endothelium. And we can also modulate the contractility of the trabecular meshwork cells, a very important thing. And this is a cartoon showing all what we expect from the future. We can have many candidates for glaucoma treatment acting on the trabecular meshwork outflow, and we can have the uveoscleral outflow enhancers and aqueous humor production suppressors. And we can see the cannabinoids I'll deal with in a slide later, which are very important. A very important group in near future, is going to be the Rho kinase inhibitors. The Rho family is a group of GTPases. is an enzyme, and it has a very important central role in cellular processes. They act the actin skeleton activity, so they act on the trabecular endothelial cells, and they may result in cell contraction and motility, so acting the actin-myosin related physiology in humans. And Rho-associated protein kinase is termed as a ROCK, and it is a downstream effector of Rho. And when you inhibit the ROCK, there will be changes in the actin cytoskeleton, especially in the trabecular meshwork cells. So Rho kinases are expressed in the ocular tissues, including the trabecular meshwork and also the ciliary muscles, ciliary epithelium. And inhibition of the ROCK activity induces some alterations like changes in the migration, adhesion, and the cellular changes. We can readily see that this is a ROCK-treated trabecular meshwork, and the passage of proteins is really enhanced. And there is also increased blood flow to the optic nerve head and a possible delay of optic nerve cell death, and which has been also reported in the experimental models. So when we use a Rho kinase inhibitor, there will be significant IOP lowering effects. There might be an improvement in the ocular blood flow and inhibition of postoperative scarring, which is very good for our trabeculectomies or filtering surgery, and there will be promotion of retinal ganglion cell survival and also the axon regeneration. And over the past decade, an enormous number of ROCK inhibitor candidates have failed during clinical testing. Nonetheless, we have still surviving ROCK inhibitors. And looking at the human clinical trials, among the farthest, the oldest one in the clinical trial process is K115, developed by COA. And during the phase 2 trials, dose response treatment of 210 patients with primary open-angle glaucoma or ocular hypertension resulted in a mean IOP reduction of almost 5 millimeters mercury. Another promising ROCK inhibitor is designed for glaucoma therapy by an American company, the AIRI, and the phase 2B demonstrated that almost a 6 millimeter mercury decrease can be accomplished with this medication. And there is also a triple action, a combination of ROCK inhibitor with latanoprost. We have now new prostaglandins in our pipeline, and a second generation of prostaglandin F2 alpha agonist, AR102, has 150-fold greater selectivity for the receptor and 30-fold greater potency at the FP receptor. So it is much better in its action efficacy in comparison with latanoprost. And this product is delivered, planned to be delivered as an ocular implant by the AIRI company in the United States. And we are re-evaluating the inflammatory prostaglandins like the prostaglandin E2 analogs like butoprost. We will see what the future will bring us. And we have potential latanoprost and nitric oxide donating molecules. If a molecule donates nitric oxide, this means ciliary muscle relaxation, which will enhance the outflow in another way. Cholesterol lowering statins may have some role in the future. And also the cannabinoids, they are very important. Cannabinoids are really the most of the very potential IOP lowering agents. And we know that the human eye has cannabinoid 1 and 2 receptors, and noladine is a synthetic cannabinoid. When given topically, lowers IOP immediately and with a maximum efficacy of almost 20% 2 hours after administration. And we have the anacortev acetate, the steroid without steroid action, and mifepristone as an antiprogesterone steroid and some diuretics. Is it possible to do vasoprotection? Yes, as mentioned in neuroprotection with L-name or with the minoguanidine, it is possible, but it has not been reflected into our clinical practice. We have some endothelin blockers like the calcium channel blockers. Now I think it is just the right time to skip into genetics. And can we change the gene, or can we repair the genes, the diseased genes, or can we add something new to the genes? I think this is a very good cartoon, and just showing us the family life and who is actually the dominant character in Turkish and in Greek families. I know that they're very similar family lives, although it is different. This is just a summary. If you have a gene-based therapy, and if you can deliver this into the anterior chamber, you can lower the intraocular pressure. But if you deliver the genes to the posterior chamber, you can repair the ganglion cells, the retinal ganglion cells, and also you can protect the ganglion cells. You can also deliver the neurotrophic factors to the posterior chamber by gene delivery methods. Stem cells should also deserve some special mention, and also we can with the stem cells we can repair the damaged trabecular meshwork, and also we can just replace the retinal ganglion cells. This is a very nice photo showing that when the genes are injected with adenoviral transfer system into the posterior chamber, into the vitreous, the green Miller cells and the photoreceptors and the ganglion cells shows that the genes are actually taking place in various cells of the retina. So the viral vectors are very effective in this respect, and if you are using an adenovirus, which is the most common form, this is good for the anterior segment. But for the posterior segment, we should use adeno-associated viral vectors that have selective tropism for the retinal ganglion cells. And with gene therapy, you can modulate the biochemistry of normal and abnormal cells. You can modulate the activity of TGF-beta2, and also you can change the cytoskeleton, and you can just make disruption of cell-to-cell and cell-to-matrix adhesions. Maybe a very important topic is the stem cell therapy. Do we have stem cell therapy in the trabecular meshwork? Yes. Just beneath the Schwab's line, we have the insert cells, which are actually different from the remaining trabecular meshwork cells, and they are the stem cells. And these can be just used as explants after cell culturing, and much better than the embryonic stem cells. And experimental studies show that mesenchymal stem cells and mature retinal ganglion cells may be used to replace. Last but not least, we have novel drug delivery methods, and these are just on the horizon, and these are namely most outstanding are the nanocarriers, and nanocarriers may be used as nanoparticles. We are also dealing with those in our experimental studies, and dendrimers and liposomes, and the nanoparticles can be engineered from natural or biocompatible artificial polymers. And experimentally, carbonic anhydrase inhibitors can be successfully attached to these nanocarriers, and we have also stimuli responsive nanoproteins, nanocarriers, and this is good for another aim, self-regulated drug delivery. As as a conclusion, IOP lowering will still remain the most important therapeutic strategy over the next decade. However, recent advances in the fields of neurobiology, genetics, and nanotechnology point to a number of novel promising glaucoma therapies in the 21st century. Thank you very much for your attention.
Thank you, Murat. Έχουμε περίπου 15 λεπτά για συζήτηση. Θα ξεκινήσω εγώ ρωτώντας τον κάθε ομιλητή για ένα τουλάχιστον θέμα και μετά ευχαρίστως όποιος θέλει να ρωτήσει κάτι θα χαρούμε.